So thank you all. The talks were just fantastic, and then the reactors did such a nice job of both summarizing and kind of pulling together new points. And so it's been really fun to be here. So instead of summarizing more, I'm going to take the opportunity to just maybe ask the first question. So when you talked, Chris, about social media, this kind of encouragement of investigators, researchers, practitioners to really use those platforms. But you also talked about kind of traditional versus new media. And there are two pieces. One is, I'm not sure that people feel competent or confident in their skills to do that. And I'm also not sure that people understand. So we talk about kind of a thoughtful approach and a plan, but the timing of what happens when you send out a tweet or you develop a Facebook platform is really different than when you write a paper and it goes through your media group and all of this stuff happens. I mean, somebody's sitting on their couch at night and they decide they want to say something, and the next thing you know, you've blown up 5 years of work by accident. And so I wondered if you might help the people in the room, as well as maybe the people who are listening online, to think about how to really increase their skills, their competence, their comfort, their ability to do this well, so that they can create these conversations that you're talking about. Because I'm pretty sure that most of us maybe worry about that, and it feels much more visible than other forms of traditional communication where we have kind of the protection of the institution at any time. So I'd love to hear some more words about that.
I think that has interesting parallels to the risk perception argument that we had earlier and the numeracy. Whereas, if you don't have a lot of people following you on Twitter and you just get on there and you say something, then your risk is a lot less because people aren't going to see what you say. But it is difficult to think about that risk. But for people who do not, let's use Twitter as an example. For people who do not use that at all, what I would suggest is that you just get on there and you don't have to say anything at first. You can follow a number of people. There are a number of great, Francis Collins is on Twitter. Carla and I are on Twitter. There are a number of people that you can follow and watch and see how people do things. Can you do something wrong and say something? Yeah, absolutely. But, in general, common sense holds out. There are things that you should not say publicly anyway, generally, and that's what gets you in trouble, right? So a lot of yeah, you're right. Well, right. Some people, right. A lot of universities also have policies for social media that you should look at, and they also have communications officers who will help you with that. And I also would add, I think you need to think about who your audience is. So there are a number of scientists, particularly in genetics and genomics where I live, who are talking to each other more, and so they're really, that's who they're aiming at. They're not necessarily trying to reach the public. And I think that's good. I think it's also good to, realize that as a scientist or as a clinician, people also are interested in how you do your job. So Sharon Plon at Baylor is a great example. She does exome sequencing, particularly in cancer, and she actually live tweets the sign outs of when they're signing out cases. And so it's just very interesting. And she can do that in a way that doesn't reveal patient privacy. But, it's interesting. We struggle with this. We saw these mutations. We did this, right? So I think what I would do is just watch for a while.
That helps. Thank you. So we'll open the floor for 45 minutes, I think. Is that right? 45 minutes? And we'll start with roundtable members. Melinda.
Thank you for another very interesting panel. I've always thought the part about the definition of health literacy that includes the ability to communicate has been kind of underused. But I thought your panel reminded me of my own experience where that has really been important, and I think will become more important with precision medicine. And that is how, as a parent or a caregiver or a significant other, how do we talk to our loved ones about the condition they have? And is the community, whatever that professional community is, are they preparing us to do that? So in my case, my son has a chromosomal disorder. So I wasn't at the doctor's office when he got curious about that. So it was my job. Nobody prepared me to do that. But it's in our official definition that we should include that as a part of helping people be health literate. And so I think this is a good group to talk about that and what's happening and where can we do better at that.
I think that's a great point. I think now communities and organizations are getting more aware of the importance of the caregiver and the role of that. I think some of the things we do in clinical practice is if someone isn't there who's a caregiver is invite them back or set up a conversation at a later time with that person because their questions may be very different from that of the person who's there at that particular visit. There's a lot of telephone, phone call, a lot of referral to a website perhaps initially to get information and then bringing the caregiver, the significant other back into the conversation. So that's some of it. It hasn't been, you're right, it hasn't been, if you're not there at that point in time during that maybe initial consultation, brought into the equation. And it's important to have
Or
that
even
conversation.
to know when and
Or
how.
when,
Not,
yeah.
not, yeah.
Yeah, and I think that's very personal, and that's where personalized medicine and precision medicine come. At what point at certain points, maybe the caregiver says, no, I'm going to let him or her be very independent, take this on. But at a later point, maybe with dementia or something, I'm going to step in. So very personalized, individualized conversations.
I think that's obviously an area where social media can help out. And my education colleagues talk to me a lot about just-in-time information. So we can create all this information, but until people are ready to receive it, it should be there when they're ready for it, right? Which is, as you say, difficult to know, right? When are people ready for it? I think social media can help because it is creating a platform where people who need that information then are able to find each other. So there are groups on, I just got a diagnosis of Prader-Willi syndrome. What do I do next, right? We give out a packet that is, you just got a diagnosis of autism. Here's what we suggest in your first 100 days, for example. So it's that kind of stuff that we can really think about what it's like to get that information and give resources when people are ready for them.
I'd like to add too, because I know we talk a lot about what is the definition of health literacy, and we talk about it as being a skill set that includes the ability to get information. And we assume when we say that we mean factual information. But people who are well educated still struggle with their ability to find factual information and to distinguish between what's factual and what is not factual, particularly on social media. So that is an area that is not really been well discussed yet, and I think we have some room for that.
Thank you, Wilma Alvarado, Little Roundtable member. And just on the other side of the coin to Linda's question and comment is, for example, if there is no history of a certain diagnosis in the family, and then that individual now is the first person in the family to have that diagnosis, how can that individual be prepared to share that information with other family members? Because again, sometimes, as Steve said, when you get the cancer diagnosis, that's kind of like all you hear. But then you also have to have the wherewithal when you have that 1 degree now to share that information. So how, what guidance can you all provide on how to have those conversations, especially when other family members are not and even if they are in the healthcare world, when it's you or a loved one not feeling 100%, you're a different person.
So yeah, with those de novo mutations and things that come up like that in clinical practice, I think one of the important things, and we talked about it earlier, is recognizing if that individual's coming in and they're clearly, kind of shut down and just had that diagnosis, that's not the time to dive into it. It might be more a support counseling type of session. It's going to be okay. We're going to kind of tell you the things you need to know. You're going to tell us what you want to know and so forth. Just whatever they need. Literature, referral to a support group, telling the other family members, yes, it's something new, you all may not have it, be supportive. It's just all of those things that come together in a very personalized way. It has to be appropriate to their literacy and their language on their terms in sound bites that are understandable, and it may take 3, 4, 5 sessions to do that.
Yeah, I completely agree with Kathleen. I think, obviously, as we learned earlier, genetic counselors are very helpful for that as well. I want to extend that as well to say in things like autism. So now we have 100 genes that we feel are implicated to some level. There are a number of places that are doing microarray tests. About 20% of the time we find variants that we have seen linked to autism. But how do I communicate that to the family? Well, this variant has been linked to autism. How is it linked? We don't know. What does it do? We don't know, right? So that is difficult. So that is a new area that we're entering, and we have to develop the tools, just as you're saying, to be able to tell them that. We also have to address the area of fault. We see that a lot of people feel guilty, like they pass that on, that kind of thing. So we have to be able to address that as well.
Thank you. Michael Valer. Carla, you brought up an issue that I was thinking about for a little while here, which is this sort of mythology, urban legend that can kind of arise out of topics that are very complex and very difficult to understand and scary in a lot of ways. You know, the whole thing about, well, what are they doing with my samples? And you're dealing with my genes. And, you know, it's not a big leap to think that people might start linking things, you know, GMO and frankenfood, and oh my God, now they're looking at my genes and what's going on here. Have there been conversations held about this particular thing, Rumor Central, you know, ways to sort of deal with that so that some of those things can kind of just be, you know, headed off early on?
No, I think this is, I brought the point up because we have currently a partnership where we've brought together about 14 people from around the country. We recognize these are not necessarily representatives of every group in the country, but they do represent individuals who are tribal liaisons, who are working with African American communities, communities from health advocacy groups, educators. And we meet with them monthly to understand from their perspective what their communities want to know and need to know about this topic. And one of the first things we did with them was create an infographics. I was very interested in Dr. Bakken talking about her infographic. It took us a year to do because it was really created from the outside in, where they provided us with their thoughts and what information we needed to put on there. But again, I think that's very time consuming, but it was also very important to build trust with them so that they could provide us with true insight into what it is they're concerned about, and not feeling as though their concerns would be unmet or that their concerns are not valuable. So again, I think our approach to this has been to try to truly take a grassroots effort and to find as many individuals from communities that we can talk to so that we can figure out how to allay those fears. Because this is something that does come up and something that they're very concerned about. And I think they're now more willing to be part of the precision medicine initiative because they feel as though they have a healthier idea about what it is and have a better way of getting the information into their communities with our support.
I'll just add, when the Precision Medicine Initiative was launched, we actually went out into the community, into the Washington Heights community, to explain what is precision medicine, what does this mean to you, or what do you want it to mean to you, and getting that feedback and bringing that back in, talking at town halls and clinical settings and other churches, places where people are comfortable telling us what they want.
I'm going to go out on a limb and add that our current election is an analogy for this in some way, that misinformation may be easier to spread than the right information, but that doesn't mean that we should not keep putting the right information out there.
I'm so intrigued and challenged by this communicating with the public in ways that they use to communicate. And, you know, Corey said they want to move research from the bookshelf to actual use. And so I just wanted to tell you a quick story. Based on the New York Times Science Times, which is the journal I prefer, I began to bing around to a head of pharmacology at my med school who's a meth researcher, head of regional addiction treatment, a couple of physicians interested in this, about this article, which was new treatments for addiction, evidence from these new treatments for addiction beyond the 12th step. So we binged around, and while, Chris, I wanted to tell you, while you were talking, he said, based on these emails, the head of pharmacology, he wrote an article for the Inquirer, which is a local version of like the National Inquisitor. And I went, oh my goodness. And then I wrote him and said, do you have a Twitter account? You know, like hashtag answers about meth, or, you know, it's intriguing to me about how you reach people. They're not going to go to the National Library of Congress looking for stuff. I don't even know if they read the newspaper. Um, and so it's just, but it has to be, I mean, if we put it out, I don't know if I would ever write a column for the Inquisitor, but it has to be actual, factual. But that's just intriguing to me that, would you have a comment on that? Have you ever written an article for
So, no. I was one of the editors of a blog called Double X Science, and our goal was to take hardcore science topics and write them at the same level that you find in quote unquote women's magazines, so Glamour, Elle, that kind of thing. And so I had the challenge of writing about the SCOTUS decision on BRCA1 testing, for example, and talking about what that would mean for you. We had people who write about black holes and whatever, and just distill that down. I think that gets it to what we heard in the very first panel, which is the tension between accuracy and completeness, right? You can cover topics in an accurate way and not necessarily what you would consider complete, and still get a lot of information across. So.
In New York, we have Telemundo, so that's a way of communicating with the Latino population, but you can do it in a very accurate way with some of the folks who are bilingual, translating the message that way, because that's what the folks are listening to.
So, Terry, did I hear in your comments a call for the members of the roundtable to become opinion leaders on Twitter? So how many people on the roundtable are on Twitter? Good. I'm going to start following a few of you.
See, it was a real question. I wasn't joking. Bernie.
Should we try again? Yeah. So let me pick up a little bit on Michael's question, and that is, how do you effectively communicate misinformation, particularly when it is emotionally charged? And the autism is a terrific example of that, particularly the internet and the area of immunization, which was so much headline in the news with misinformation, which has led to measles epidemics, most recently perhaps in Disney, mumps epidemics, perhaps in the sports world. So how do we effectively communicate misinformation? Yeah, communicate. Well, communicate, yeah, well, right. Right. So you know my point.
Like counteracting?
How do you counteract? Or right.
So I
Counteract.
I would argue that you see this oftentimes on Twitter. People will hijack the hashtag. And so if there's a hashtag that relates to something inflammatory, people will hijack that and put actual science facts in there, or facts about whatever it is, the topic in there. You're right. Every time I give this talk on social media, I'm asked to answer for two things. The first one is about trolls on the internet, which is kind of what you were getting at. And the second one's about vaccines. So already we're 10 minutes in and I got them both. So it's good. So how do we effectively communicate the right information? That's one way, I think, as Carl was getting at, as we were getting at, using, meeting people where they are, using those hashtags. I think it's also important to, as we talked about as well, recognize there is emotional stuff about this. Don't come in with the attitude of you're just wrong, you don't understand, you're not accepting the information. I have two friends who are science writers, Tara Haley and Emily Willingham, and they've just come out with an evidence-based guide to parenting, which I think will be very helpful. And it doesn't take the tone of, if you don't follow this, you're just wrong. It takes the tone of, you know what, here are the studies, here are the data. You should look at the data, you can make your own decisions. These are the data that are out there. And they've also come up with a guide for talking to your friends about vaccines. And it advocates languages like that, like these are the data, their data out there. We have faculty at our autism center who talk about how they have family members with autism, but they chose to vaccinate their own children, even though theoretically they should be at quote unquote higher risk if that hypothesis were true, which it isn't. So just an example of that. It's just, being calm, I think, recognizing that there's emotional charge and stating, for example, what you did with your kids. I vaccinated my son, that kind of thing.
I would also add that when we had the opportunity to work with the Natural History Museum to create an exhibition, we created an exhibition that one of the goals was to provide true information about genomics. And we recognized that at the Natural History Museum, we would reach over 3 million people coming in to see this exhibition. And now the exhibition is traveling around the country, and it's going to places like Wichita, Peoria, it's in Milwaukee. Not large marketplaces, but probably places where genomics is not something that typically shows up at your local science center. So again, I realize that's probably a long-term endeavor. It's something that takes a lot of time and a lot of effort. But again, when you think about bang for your buck and reaching a lot of people who aren't necessarily going to be reading the newspapers or who may not had the last science class they took was in high school, but now you have a whole family adventure talking about a topic, that's been one of the ways that we've engaged the public in addition to holding community programming around those exhibitions as well.
So in our autism center, we had to do exactly that. We had to actually go out into the community. Using social media was not adequate enough. So we had to go out into the community, whether it be the churches or other community resources, health centers, FQHCs, all of which were able to process the information, pass the information on in a very health literate way to be successful, particularly in the area of immunization. We're going to be doing a little project on that, and it's incredible to look at the zip codes around the country, the areas around the country where immunizations are extremely low. And even within those immunization areas where the rate is low, there are practitioners who have a very high rate. So what are those practitioners doing that are different than the practitioners that have, a 2% immunization rate or a 4% immunization? We may find out as we move on this project that their communication ability may be a key factor in their high immunization rate. I don't know what we'll find, but it's something we're going to look at, health literacy.
You're also going to find that some of them have signs at the front door that say, I vaccinate all children, don't come in here if you don't want your kids vaccinated, right? So that's part as well.
So I had a question about communicating with the public and turning it around and the public communicating with us, and wondering if within this there isn't potentially a really big opportunity. Sometimes it's really hard to listen because you don't like the questions you're going to get, or you don't like the comments you're going to get. So we have structured ways that we interact in order to get input at certain times, because then we're prepared to sort of take it and deal with it. And sometimes we just don't, like the window's not open today. It's after hours. And so it seems like as we embark on particularly the PMI, where the ask is really big to try to get 1 million plus people, but I wondered about whether or not the public and whether or not we understand well enough. I do also have a recommendation that anybody funded or connected to this needs to enroll in it, because I think it would change the initiative. But if the global we're all enrolled in the PMI and all a part of this and all figuring out how to do it, how we could communicate with it, and whether or not that might really be the next generation. Do we really know what people want to know and what they're interested in, rather than this turning it around of telling them because we think they might be interested and might need it on the other side? And given that communication really is a two-way street, we still see it so much as there's some empty cups that need filling, and there's some people that have questions, and we do want to know them, but on our terms. So I just wonder if there's any thinking around that with communicating with the public, given the options of connectivity and what it could hold, and how that could structurally be a part. I think also, just as a comment, I think about like the work in the children's health, the National Children's Study. I think about the NIH's role with federal dollars in the Gulf oil spill. What is it people really wanted to know? Well, they wanted to know if they could drink the water, eat the fish out of the water, go swimming in the water, but that wasn't really what we were answering, you know. And so we get caught a lot, but if we really understand what people want, how do we engage where they are and whether or not there could be opportunity in this moving forward based on our history?
I, I think, you know, we have to get out there. We have to really engage with those advocacy groups. We have to engage with the public and hear from them. I think you're right. And I think it has to be, they have to come to forums like this. We have to really hear what they have to say. It just has to be a boots on the ground type of campaign. There's got to be media sources where they can put in those needs so that we can start to address them. I mean, it can't be us kind of telling them, and a lot of the, I'll just give some examples like the Hypertrophic Cardiomyopathy Association. Those people are passionate. They're living with that disease. Their families have it, and so they're engaged. They're trying to change legislation. They have on their website things to do if there is a sudden death in the family, what the medical examiner should collect in regards to tissue or blood. So I mean, it's really getting them at the table.
I think it's interesting your suggestion that everybody in the PMI should have to, who gets money, should have to enroll. So I went to the European Society of Human Genetics this summer, and they had a debate amongst the people there, and asked should geneticists get their genome sequenced. And my own opinion was, yeah, why not? Right? I've done some of that, sure, why not? And the majority of people there at the European Society said no. And they had all kind of different reasons. But even, you know, getting back to cultural competencies, meeting people where they are, the majority of them said no. And I was just kind of left scratching my what? And they had reasons like, if you do that, you're taking away resources that you should be using on patients, for example. And these are all reasonable reasons, right? Just different ways of coming at stuff. So you may find some resistance there for that.
Just to follow up, anything from the ground up in terms of feeding into it? Like, here's what we're interested in. Here are our questions about it. Here's where we'd like to see, versus, you know, not just the town hall, there's a website, post it by X and then it closes, but as part of going forward in terms of incentivizing. You know, this is something that you can be a part of and give voice to, and we're going to have 1 million people in all at once. We could know what the top 5 questions are among those 1 million people regarding this condition, that condition, what they want to know, this year's election, how it affects it, our nation, top health priorities. You know, truly a voice of people in terms of what their interests are.
I think one of the challenges is that, it's hard to think about doing it as a million person collective. I mean, the issue would be you would really be working with small groups initially to get the information. And I think sometimes we're somewhat reticent to that because we like to deal with big numbers. Everybody wants to see 1 million people, but the reality is if you're going into Flint, you may only get 50 people who ask the question, but that's okay. That's 50 people in Flint. And if you're working with tribal communities, you may only see 100 people who have that question, but those are no less valuable. So, I think one of the things that we've tried to do is really meet people where there are important opportunities. So for instance, with the exhibit, we did a military family day. And so again, military families were not the typical group that came to the museum. But if you provide them lunch and free admission, they will come to Military Family Day. And you can then have a collective group of people who've not been engaged before, but now are willing to answer those questions because they're there. So again, I think it's slow, and it's sometimes a bit frustrating for us because we want things quickly. But I do think finding these groups of folks and collectively bringing all that information is well worth it. We just have to recognize it's not going to be as quick. I always think about, I had a conversation with a Native American I was at a Native American conference, and they used the word inshallah, in God's time. We're so used to working so quickly, but everybody else doesn't work in the time that we work, and we just have to respect that. And so I think taking that same thought process forward, PMI is a multi-year initiative, so we just have to think it may take us multi-years to find all the answers that we need. Just been our experience working with communities.
And I'm going to add a crucial component to make that happen is putting money into budgets for grants to allow us to go into communities and do recruiting there. And that's often something that either gets cut out or sometimes drags the grant down. Reviewers rate that negatively, but that is so important to do exactly what you're asking for, what Carla's talking about, being able to actually go into the shoe leather approach like Bernie said.
You gave us a few extra minutes. That's terrific.